Today I'm going to talk on a very specific topic. What is the evidence-based mantras for Adnexal masses in adolescent? This presentation provides a strong evidence-based approach to evaluate and manage adolescent adnexal masses while ensuring great workup, few therapeutic tips, optimal fertility preservation, and cancer risk reduction. You can see this particular slide. There is no age when the masses cannot occur. Right in the childhood, adolescent, adulthood, postmenopausal period. But focusing on adolescents, you can see that the neoplasm can be benign, it can be malignant, and they can be non-gynecological causes as well. When we talk about adnexa, I don't have to tell through this August gathering what adnexa means. Is the tubes and the ovaries combined together. Incidence matters. Adnexal masses are found in 2.5 to 7% of adolescents, and your experience shows that most are benign, but 10 to 20% are malignant. I've quoted the evidence which has been the latest from where I've taken the figures. Coming to functional versus pathological masses, 70 to 80% are functional cysts and which resolve within 6 to 8 weeks. As far as age and risk stratification is concerned, we all know that the risk of malignancy increases with age. It's only 3 to 5% in adolescent period, while it is 10 to 30% in postmenopausal women. As for the germ cell tumors are concerned, they are a big cause of concern. 60 to 70% ovarian malignancies in adolescent period are germ cell tumors, most of which are curable with fertility-sparing surgery and chemotherapy. The silent killer is dysgerminoma. The most common malignant ovarian tumor in adolescent is dysgerminoma, but it has a 95% survival rate with early treatment. It presents rarely in pediatric age as torsion. Never ignore a solid mass, because 20 to 25% solid ovarian masses in adolescents are malignant, and that's why you have to evaluate them thoroughly. Borderline tumors do exist. 10 to 15% of the ovarian tumors in adolescents are borderline tumors, requiring long-term follow-up, but often fertility-sparing surgery is possible in such cases. As for the ovarian torsion is concerned, it's a surgical emergency. 15% of adolescent adnexal masses are associated with torsion, requiring immediate detorsion to save the ovary. The teratomas are the rule. As for the benign pathology is concerned, mature teratomas, that is dermoids, account for 50% of the benign ovarian tumors in adolescents and have a low malignancy rate of less than 1%. We must be beware of endometriomas in teens. 50% of adolescents with chronic pelvic pain and adnexal masses have endometriosis. So early diagnosis is the key to preventing infertility. Do not rush for surgery unless big or very big mass. Long-term medical treatment has to be planned to avoid chronic complications. The rule of surgery in such patients is once in a lifetime, and the experts should do it. As for the PID-associated tubo-ovarian masses are concerned, you can find it varies from 5 to 15% in hospitalized adolescent girls, with PID developing as tubo-ovarian masses. It requires intravenous antibiotics and sometimes drainage. And I think as we stay in India, which is country hub for tuberculosis, do not forget whenever adnexal mass is presenting that you should not miss the diagnosis of tuberculosis. As for the clinical assessment is concerned, that's always the key. History, the physical examination to evaluate pain, menstrual changes, and the signs of virilization, signs of precocious puberty should not be missed. Coming in little detail, as far as the symptoms are concerned, quite a few are asymptomatic, accidental finding that you find in adnexal masses. Whenever there's a pelvic pain, you need to define the degree, whether it's mild, moderate, or severe. If there's an acute pain, the girl is rolling in pain, always think of torsion, rupture, or hemorrhage. Menstrual irregularity should always be taken into account. As for the examination is concerned, we got to look for tenderness, both abdominal and pelvic. And the mass size has to be seen, its consistency and mobility has to be evaluated. The golden rule for ultrasound is that you do ultrasound as far as the first investigation is concerned, ultrasound with Doppler. It's the first line of investigation. Pelvic ultrasound, transvaginal or transabdominal sonography is 90% sensitivity and almost 90% specificity. Here, people get confused in the sensitivity and specificity. I have a mass and my finding is positive. That is called sensitivity. I do not have a mass. And if it is negative, that is called specificity. As for the imaging is concerned, use transabdominal ultrasound as a first-line imaging tool due to safety, accessibility. Transvaginal is ideal, but we avoid it unless she is sexually active. Good alternative is transrectal ultrasound, but expertise is needed. Everybody can't do and interpret transrectal ultrasounds. As for the ultrasound is concerned, we call it a simple functional cyst. If it is less than 5 centimeter, thin-walled, anechoic, no septation or solid mass. Observe and repeat ultrasound after 8 weeks for you to know which way it is going. As for the complex and the solid mass is concerned, it is more than 5 centimeter. Septations and solid areas are there, and the Doppler flow is noted. MRI is done for indeterminate masses. Utilize MRI for these cases to refine diagnosis and surgical planning. MRI is 95% accurate in differentiating benign versus malignant. If it happens to be child, then the child has to be sedated before you do an MRI. And this is only needed when the diagnosis is inconclusive by ultrasound, not otherwise. Step 3 is tumor markers. Again, we gynecologists get confused. The germ cell tumor panel is AFP, HCG, and LDH. For the sex cord tumors is inhibin A and B and testosterone, and epithelial tumors is CA125 and CEA. We must avoid routine CA125 because low specificity is there as far as the CA125 is concerned in the adolescent. Reserve CA125 for high-risk cases whenever there is a strong family history of epithelial ovarian cancers. Elevated AFP is seen in yolk sac tumor, elevated HCG in dysgerminoma and choriocarcinoma. As for the triage torsion is concerned, suspect torsion whenever there is an acute pain, nausea and vomiting. And on ultrasound, there's an absent Doppler flow. Prioritize emergency laparoscopic surgical intervention. The salvage torsion timely to detort it because ovarian preservation is invariably needed unless you find by the time you have opened up and done intervention, it is necrotic. The immediate surgery time is cut off is less than 8 hours to improve ovarian salvage rate. If you do later than this, then you'll find you'll probably lose the ovary. Patients who are premenarchal, the vigilance is all the more needed due to higher chances of malignancy. As for the functional cyst is concerned, the management tips are that cysts less than 5 centimeter who are asymptomatic should be followed for 6 to 8 weeks with ultrasound before intervention. If it is persistent or enlarging in size, reevaluate for benign pathology. Benign neoplasms are dermoids, cystadenoma, endometrioma. More than 5 centimeter, the patient who's symptomatic, growing, laparoscopy cystectomy has to be done for ovarian conservation. When to consider surgery for cyst? Whenever you find the cyst size is 8 centimeter or more, it is persistent beyond 3 cycles, complex features, or has suspicion of malignancy, you require surgery. Hormone therapy for functional cyst. I just wish to tell you it was a little surprising for me when I came to know about 6 months back that we all give left and right COC. Consider COC to reduce recurrent functional cyst. This is evidence. OCP do not hasten resolution of functional cyst, but they can prevent recurrence of cyst. As for the complex mass workup is concerned, investigate complex and solid masses rigorously to exclude malignancy. Watch for rapid growth. Fast-growing masses in adolescents are suspicious for germ cell tumors or torsion, and urgent evaluation is needed in such cases. You require team-based care, so beside gynecologists, oncologists, and radiologists. Oncology referral is needed whenever you suspect malignancies to pediatric oncology centers. Suspect malignancy. Whenever it is solid, rapid growth, high tumor markers, and MRI for further characterization. Oncology referral in such patients is required, and one has to plan fertility-sparing surgery in such cases. Gone are the days when an ordinary gynecologist could do surgery left and right, but not anymore. As for the intraoperative frozen section is concerned, whenever you suspect malignancy, this facility must be available. And I again repeat that minimum invasive surgery has to be done to reduce morbidity and enhance recovery in such tender age. Post-operative surveillance is required to monitor with imaging, monitor with tumor markers, and for this one has to use regular ultrasound monitoring, menstrual health and hormonal balance. Patient and family counsel is needed for reassurance, fertility concerns, and recurrence risk. Chemotherapy for germ cell tumor, I advocate because it's very effective whenever there is a germ cell malignancy, and the therapy which is used is platinum-based chemotherapy, BEP regime. As for the bilateral masses are concerned, think syndromic. I have listed 3 syndromes. I have not seen in my lifetime any of such cases. Whenever there's a large ovaries in polycystic ovarian disease, they are not the masses. Ovarian volume more than 10 centimeter with multiple cysts suggests PCOS and not adnexal masses. So one has to be careful for such cases. Beware of precocious puberty with masses. Always think of hormone-secreting tumors and investigate on those lines, getting hormone assay done. Granulosa tumors in young girls may present with precocious puberty, prompt endocrinological workup, and the referral is required. As for the paratubal cysts are concerned, 10 to 20% of adnexal adolescent masses are paratubal, which are benign and often asymptomatic. Now, I repeat many facts again to re-emphasize the points for gynecologists. Fertility counseling is very, very important. Discuss ovarian preservation and fertility option preoperatively. Failing to do that speaks very negatively about you. Fertility preservation in malignancy. 90% of adolescent ovarian malignancy can be managed with fertility-sparing surgery. The surgery which is opted is unilateral salping oophorectomy in early stage cases. And always think of conserving ovarian tissue. Perform cystectomy over oophorectomy when feasible. Conservative management of benign tumors saves ovarian reserve. Cystectomy versus oophorectomy. The cystectomy preserves ovarian function and should be preferred for benign masses. Conservative dermoid treatment. People rush for dermoid less than 5 centimeter. Asymptomatic mature teratomas of less than 5 centimeters can be monitored and you can wait. Do not rush for surgery for small dermoid in teenage. The role of genetics in malignancy. BRCA mutation increases the risk of ovarian cancer risk. The family history must be assessed in adolescents with suspicious masses. Family history is very important. Ovarian cancer in general population is 1 to 2%, but if BRCA1 is positive, this increases to 40 to 45%. And if BRCA2 is there, the incidence jumps of ovarian cancer from 11 to 15%. Beware of the solid masses in Turner syndrome. 45X Turner syndrome patients has a 15 to 20% risk of gonadoblastoma, which requires early gonadectomy. Endometriosis consideration, I repeat again, people rush in for surgery. One has to be very kind to these adolescent girls. Exclude ectopic pregnancy. Always, whenever you feel that she's your daughter's, she's your sister, friend's daughter, and things like this, you don't think on pregnancy lines. You should definitely think in pregnancy lines because ectopic can be there. And this can be easily picked up by beta-HCG as well as in urine pregnancy tests. Long-term follow-up is very much required after malignancy in people who are survivors for malignancy, and because they in future can be concerned for infertility as well as for secondary cancers. Psychological support, integrate mental health services to address the anxiety and the trauma of these adolescent girls. Family education is required to recognize torsion. Whenever there is a big cyst, you know that it can have a torsion. You have to tell the family members and the parents that what can be the features, and torsion, rupture signs, sudden pain and vomitings are there in such cases. Now, these guidelines and the evidence and the references align with ACOG, FIGO recommendations, emphasizing risk stratification, imaging, fertility preservation, and multidisciplinary care. Tips are given on germ cell chemotherapy, laparoscopic benefits, and torsion and management outcomes.